the more acute effects and the big challenge for diabetes is, of course, to control the glucose levels. And the major player is still insulin. I mean, there's no doubt. And so we were obviously able to control the disease, reasonably well with insulin. But I think the other problem, and I think you alluded to that a little bit in your questions, is it's more of a symptomatic approach. It's really just treating the symptom, namely the high glucose, and that is best done with insulin. There's no doubt about that.
Thank you for clarifying that. And again, I really want to put myself in the position of the audience who is just not as experienced with the biology and the science behind diabetes. So thank you for the explanation. And we've talked already, about how TX100 would be beneficial for someone with type 1 diabetes. But talk to me a little bit about type 2 diabetes, and then even as well as early onset type 1. If we were able to identify, the antibodies early, what impact would TXimed have or TX100 have for those patients?
Right. So again, I think another myth that, as much as people were thinking that all beta cells are lost in onset of once there's onset of type 1 diabetes, the other myth has been that type 2 diabetes is only based on kind of insulin resistance and has nothing to do with the beta cell. And we know that that is not true. Type 2 diabetes is, like type 1 diabetes, ultimately dependent on the loss of functioning beta cells. The only difference is that that loss of beta cell function is a lot slower. So that slope is a lot flatter. So in a way, actually, we have even greater opportunities to treat type 2 diabetes with approaches that target the beta cell because we have more time. So by the time someone is diagnosed with type 2 diabetes, they typically still have a significant amount of beta cell function left. So imagine if you target at that point, you can preserve the beta cell function. And in fact, if we do this right, we might be able to avoid having people to go on insulin in the context of type 2 diabetes. So there actually, it could be preventative in terms of not having to use insulin. To your other question, in terms of early type 1 diabetes, again, I think the earlier we can start the treatment, obviously, the better, because that's when more beta cells are still there and more beta cells are preserved. The earlier we start, the less insulin the patient would require down the road. And if we do it really early, at a time where still beta cell functions are sufficient to sustain normal glucose levels, maybe insulin requirements could be avoided altogether. Later in the disease process, it probably just would be a reduction in insulin requirements.
Fascinating. I think there's a lot of I want to unpack there, but I think something that is really interesting for me to translate for our listeners, because we've been talking a lot about diabetes stigma on this podcast this year, particularly within the diabetes community across from type 2 or type 1 to type 2, and explaining that to people in our various lives, right? And oftentimes there can be sort of microaggressions or misinformation and stigma from the type 1 community to the type 2. But you said something really interesting, that type 1 diabetes and type 2 diabetes are more similar than maybe we realize. And could you expand on that a little bit and think about, or in a way that, our audience could learn a little bit about how the diseases are more similar than maybe we think?